Well, I'm Butch Levy. I'm a primary care doc, and I'm writing content for a nonprofit free patient website on cancer. And I've been looking at your work for a long time. I actually tried to send you a couple of patients, but there's seems to be a little bit of resistance in the oncology community of sending tissue samples. So people, when I was in Colorado, it didn't work, but I wanted to provide a short interview that we could put up on the website so that people that are looking for as much information as they can about how to deal with their cancer have the opportunity to do that.
Sure.
And you've been doing this. I was interested. Were you originally an internal medicine physician?
No, I did my internal medicine residency and went right to an oncology fellowship, and from there right to a hematology fellowship. So I never practiced. I
Okay,
went right to oncology.
okay, all right. And where was your training?
Depending on how far back you want to go, I did a chemistry degree at Boston University as an undergraduate. I graduated from McGill University in Montreal for medical school. I did a residency in internal medicine here in California at the University of California, Irvine.
Oh,
I then went to Georgetown University for a fellowship in medical oncology. And then I went back to Scripps Institute in La Jolla for a fellowship in hematology. I then left La Jolla and joined the faculty at UC Irvine. And I was on faculty at UC Irvine until I set up a biotech company. And I've remained on faculty at UC Irvine in a teaching capacity.
so how did you evolve from clinical chemotherapy? I mean, you're doing very interesting work now, and it seems like you've moved into dedicating your background and your abilities into helping patients make better decisions about their treatments. And that seems to be a little different view than perhaps how conventional oncology looks at that. Was there a point in your oncology career that you thought it wasn't being as successful as you thought it should be?
Yes, I wrote a book several years ago called Outliving Cancer. And the intent of the book was to explain to people the rationale for using their own tissue to select treatment. And the reason I chose the term outliving cancer is because over the years I had studied cancer biology in the laboratory, I had come to realize that there was one distinguishing feature of cancer that made it win over the patient. There was always one thing cancer did better, and it wasn't grow or divide or make DNA. It was survive. Cancer cells outsurvive their normal counterparts, and they live long enough to have one or two extra generations. And their offspring live long enough to have one or two extra generations. Now, that may not come as such a surprise, because if you think about it, most cancers arise in patients 20 to 30 to 40 years before you find them. Now, if cancers were growing quickly, it would take a lot more than 40 years to find, it would take a lot less than 40 years to find them. So clearly they're doing something that enables them to get a leg up, but they're not really growing rapidly. Most cancer cells don't grow rapidly. So when I realized that, I thought, maybe we could test that hypothesis. And when I was a medical resident here in California, I met a guy who was working in this field, and I moved into his laboratory briefly, and I began to study cancer. I began to study why cancer cells die. What do they do? Now, at the time, everybody was working on something called a clonogenic assay, and that was a cancer stem cell or growth assay. It seemed obvious to me from the get-go that it wasn't a very good technology. I didn't like it at all. It was cumbersome. It was rarely successful. It was inefficient. It was expensive. It took a long time. I liked nothing about it. And when I realized that it didn't predict anything, I knew I was right in the first place, because it was a useless technology. But what the fundamental underpinnings of that test was growth, cancer growth. It was called the clonogenic assay. And so the idea behind it was if you expose cells to drugs and they don't grow, they don't form colonies, then you've got a good drug. And when it first launched in the 70s, everybody thought it was the cat's pajamas and it was going to be the big win. And then everybody collected all the data and realized it wasn't predicting anything. And the trouble was that the field collapsed because the degree of expectation is directly related to the degree of disappointment when something doesn't work. Like, this is so important. And then when it doesn't work, this is the worst thing ever. And that was just about the time that I was doing my fellowship in oncology. And I walked into a program dealing with very advanced malignancies, pancreas, colon, lung, and absolutely all my patients suffered through chemotherapy and died. I can only think I count on one hand people who survived care. And it wasn't anything wrong with the program. The program was good. It was just system. It was the concept of cancer, how we were treating it, what the drugs were designed to do, how they were delivered, how they were combined. Wasn't working at all. So I thought, well, if cancer might be studied in short-term culture, and if we could measure how cells die in short-term culture, maybe that's the reason what we're doing isn't working. Everyone was doing clonogenic assays and thymidine incorporation assays and proliferation measures and growth to confluency and all this stuff that wasn't working. And I thought, maybe killing cells in the test tube is the ticket. So I started a laboratory in my second year of fellowship at Georgetown to study that. And I worked at night and I worked on the weekends. And one of my colleagues was kind enough to give me a bench and to take a little extra money from his grants. And all at once, I started curing incurable leukemias. My patients who were failing therapy were suddenly getting better. And I wrote a paper about it. And I went to Toronto and I presented the paper at the American Society meetings. And I was very proud of myself. I was a second-year fellow. I had no reason to really be at ASCO presenting my own paper. But I went to Toronto and I gave my paper. And I thought, everyone's going to see this and they're going to think it's really great. And nobody cared. And I couldn't believe it. I thought, well, look at this. Look at these patients. Look at these outcomes. Look at these refractory malignancies going into remission using things people not have used. In fact, based on our studies in that one collection, I realized that the drug Ara-C, cytosine rhabdomyocyte, widely used in leukemia, I realized that the dose escalations could be achieved. And I was the first person at Georgetown to give high-dose Ara-C, based entirely on the growth, on this cytokinetics of higher doses of Ara-C. I realized that I could push the dose, and I gave it to a patient and got a complete remission when no one could get this patient in remission. And I thought all of that would lead to people saying, gee, this is really good. This is really worth doing. But when I left Georgetown, I went to Scripps. I applied it again. I set up my own laboratory and I was granted some space. And I did it again. And this time there was a patient who had hairy cell leukemia. And I had read some interesting literature on certain small molecules that might affect hairy cell. And I gave a patient's tissue. I placed it in the environment. A splenectomy was conducted. And I took these hairy cell leukemia was utterly incurable at the time, utterly incurable, completely untreatable. Basically, you just died. You had a splenectomy and then you died. So working with a guy at Scripps, a guy named Dennis Carson, who had invented a drug called chlorodeoxyadenosine, which he thought would be useful for T-cell lymphoma based on the drug actions. I got a little bit and I dumped it into my hairy cell patient's cells, and it killed all the cells. And I was sure it was going to be the treatment for hairy cell. So I went to the senior investigators at Scripps and said, look, guys, I think we made an important discovery. This drug should be in hairy cell. Oh, your test is no good. Oh, those are stupid results. I said, no, I really think this is going to be a big win. Well, one of my junior fellows, I was a senior fellow, was listening very carefully. And when I got frustrated and left Scripps and moved back to UC Irvine, he took chlorodeoxyadenosine, gave it to 12 people with hairy cell leukemia, and they all went into remission. It was the front lead article in the New England Journal of Medicine a couple of years later, my discovery. Now, the reason I tell you that is it was because people didn't want to accept the concept of human tumor primary culture as a predictor of outcome, that they stepped right around important discoveries. During that same period of time, I discovered that chlorodeoxyadenosine and closely related fludarabine were highly synergistic in CLL and related lymphoid malignancies. And that, published in the British Journal, became the standard of care for CLL for 2 decades. Not that anyone gave me credit for it, but the point is, repeatedly, these laboratory analyses identified treatments that were very, very important. And a community that was unwilling to change their way of thinking was standing in the way of patient well-being. I moved on then to solid tumors and began to develop interest in the anti-metabolite combination of gemcitabine and platinum. And the regimen that we developed, cisplatin plus gemcitabine, carboplatin plus gemcitabine, today are the standards of care in ovarian and triple-negative breast cancer. Again, we wrote the first papers, we made the discovery in the laboratory, but no one wanted to accept that the laboratory could do that. So they would take the message, but didn't want the messenger.
So can you explain a little bit what doing it in the laboratory and how you test it gives you such different results than just what the studies are showing?
I don't mean which studies you mean.
Well, let's say someone has a breast cancer and they were giving a specific chemotherapy of some kind and it wasn't working. You're saying that by using the tissue samples that you have, you can actually absolutely determine what things are going to work. Is that a correct assumption?
What the test does is to recreate the environment that the cancer cells reside in, right?
Okay.
So you take the cancer out of the body and you place it into a modified RPMI 1640 with nutrients and fetal calf serum. You place it into a 37-degree incubator. You humidify the air and you give the cells the feeling that they're still in someone's breast or colon, liver. And for a few days, those cells think that they're still home. You then introduce into that microenvironment the drugs and combinations that the doctors are thinking of using. So for example, a breast cancer patient. Breast cancers get Cytoxan. Breast cancers get doxorubicin. Breast cancers get Taxol. Breast cancers get vinorelbine. Breast cancers get mitoxantrone or carboplatin or whatever. So think about cancer cells responding to injury the way you might think about estrogen receptor positive breast cancers responding to tamoxifen. You understand the analogy?
Yes.
Tamoxifen will only work for a breast cancer if you express an estrogen receptor that can be modified by the drug.
Absolutely.
So it doesn't take a brilliant doctor to measure your estrogen receptor presence or absence and then administer a hormonal therapy accordingly. In essence, cancer cells have doxorubicin receptors or Cytoxan receptors. They're not receptors, but it's highly analogous because what makes a drug work is an inherent ability to respond to it. You see, some cells respond to DNA damage. Some cells respond to topoisomerase II inhibition. Some cells respond to antimetabolites. Some cells respond to platination. Some cells respond to G2M arrest associated with Taxol and vinorelbine. Each of these are probes of the biology of the cell. Now, I'm not saying the investigators at UCSF or Cedars-Sinai are making a mistake, but they're going into treating patients without measuring their ER positivity. They're giving everybody tamoxifen. And so it's not going to work a lot of the time. Now, when it works, it's great.
Right.
But when it doesn't work, instead of saying, gee, I wonder why that didn't work, they move on to the next and the next thing, and then finally the patient fails and dies. There was a publication today, I didn't know about it, but I had a patient from Hershey, Pennsylvania. And a colleague of mine, who's a radiation oncologist, called me a few months ago and told me that the patient was failing. He had a very bad colon cancer, and he was failing, and he failed all treatment. And he said, can you help him? And I said, well, what has he had? Oh, he's had FOLFIRI and FOLFOX and FOLFIRINOX and blah, blah, blah. I said, no, I can't help him. He said, well, he's dying. He's 43 years old. He's got young children. We got to help him. We got to do something. He said, he's already had all the drugs. I can't do anything. He said, try. So somehow or other, we convinced a surgeon in Hershey to get a good sample. We got a very good sample. And lo and behold, he was particularly sensitive to inhibitors of the MAP kinase pathway. Does that mean anything to you? Okay.
Mm-hmm.
So he was very sensitive to the drugs that influence the MAP kinase. And I said, I think this guy has a MAP kinase-driven tumor. Have we explored inhibitors for these pathways? No. So I said, well, let's run a profile and look to see where my patterns seemed to correspond to underlying MAP kinase pathway. And in fact, we realized that he was indeed a candidate for modulation of the MAP kinase pathway, and almost immediately got better. Immediately. A month later, I got a letter from a note actually to my staff, and he was extremely thankful and said, "Thank you so much for saving my life. For whatever reason, they hadn't figured out this simple treatment that's working so well for me." And then today, that article came out in the newspaper. I mean, in Hershey, I didn't know about it, but it showed up online. You can look it up. I can find it for you. And I mean, it's not like we were so brilliant, you know. It isn't like, gee, I invented something or broke the sound barrier. I just knew to flew the plane fast. You know, we just did it, you know. And I had a patient here today from City of Hope, which is a big center here, and he has really highly aggressive colon cancer. And he just had a surgery, and the surgeon was kind enough to send us a piece. And this guy also had a very, very sensitive, I mean, he's incredibly resistant to chemo, except something called a MEK inhibitor. I don't know if that means anything to you. But he's sensitive to a MEK inhibitor. And there are a bunch of MEK inhibitors in the market. Binimetinib and cobimetinib and trametinib and selumetinib.
Oh, yes,
and those drugs are selectively used for people who have BRAF tumors. Now, he doesn't have a BRAF tumor. He has a G13D tumor. But there's literature on the G13D mutation. Of all the mutations in KRAS, the G13 mutation may be more sensitive to inhibition of that pathway, and he is. So he came to see me before this interview, and we sat down and I explained what I would give him. Now, I have no idea if I can get it for him, but I think it would be very worth trying. The trouble is the drugs have only been approved for melanoma and BRAF positive colon cancer, and he doesn't have BRAF colon cancer. So the thing is, what we're running up against more and more is individualized care meets standardized care. And what we've forgotten is that good medicine is cost effective. And we're getting a lot of bad medicine because we're standardizing treatments at the very time that people want individualized treatment.
Absolutely.
So I was the pioneer in individualizing treatment. Now, there's a lot of people want to do this at the genetic level, but if you follow that literature, it's really been a bust. With the exception of the truly actionable mutations, cancer is too complicated to identify targets for which small molecules will be effective. There's handfuls of cancers. The most compelling example is CML. Chronic myelogenous leukemia responded to imatinib and dasatinib and all the derivatives because every cancer cell in that tumor carried exactly the same genetic aberrancy. They all upregulated c-Abl, and they all die when you take it away. The classic oncogene addiction. But that's the only cancer it's worked in. I mean, Tarceva is great for a year and a half. Tagrisso is good for 2. Alectinib is good for a year and a half. Lorlatinib for 2. But they don't cure anybody. There's no other disease where a small molecule developed on a gene profile has ever cured anybody. It doesn't happen.
So can you talk a little bit about how a patient is able to connect with you? It seems like getting a surgical specimen or a liquid biopsy perhaps is important, but it sounds like it's not just a primary. It sounds like people have recurrences and the treatments aren't working. If they can get a biopsy, it also is beneficial.
We make a couple of offers to our patients. Number one, for those people who can spend a brief time with us, we'll get the biopsy. We have teams of thoracic surgeons and hepatobiliary surgeons and general surgeons who will get you in and out, hopefully with day surgery, laparoscopic biopsy. So we often recommend people come here. Not that I want to take over their care, and not that I want to get in the way of their relationship with their doctors, but the tissue is so precious. A good sample is so precious that I sometimes, you see, there are a couple of ways we can do this. If you're having surgery because someone's doing a mastectomy, send me the piece. The worst that happens, I don't get it. But if you're having a surgery, if you're having a gallbladder procedure or a lung thoracoscopy, and it's for me, don't trust that to someone who's transporting it across the country in a FedEx package. Come here. So we are rather interested in getting people to come and have their surgical biopsies if possible. Now, if it's easy, like a pleural effusion or fluid in the abdomen, or an excisional lymph node biopsy, or something where the patient doesn't have to go through too much, even if it doesn't work, it's okay. But yeah, what we say is call us before any procedure is done. Enable us to look at the lay of the land and see what would be involved in getting a biopsy. If it's easy and shouldn't require travel, like this patient from Hershey, Pennsylvania, luckily, we had an enlightened surgeon who got me a great sample. Luckily, the surgeon at City of Hope sent me a good sample. But many surgeons are either unfamiliar with this or unwilling. And I just think the patient's life hangs in the balance. You cannot rely upon a disinterested doctor to save your life.
Well, and the surgeon is only doing one small part of the whole deal. Once he does the surgery, he's kind of finished with you, and you then go on to get your chemotherapy treatment. So there's that loss of connection. It's really just a procedure, and then you're done.
Right.
So
But a lot of surgeons don't want to do procedures on people with advanced or recurrent disease. See, the surgical mindset is en bloc resection for cure, right? So unless they can go in, get out, and you're done and you're cured, they don't go in. The other indication for surgery is an acute emergency, like a bowel obstruction or something like that, that requires an intervention. But a lot of the time beyond that, surgeons don't want to go in and do biopsies because they know that at the end of the biopsy, you still got cancer. So there's a kind of mindset away from using the surgical procedure to get the tissue that can save your life.
If they're doing it en bloc, that's what they did for breast cancer early on. They thought they had to take all the tissue, and it still didn't work.
Well, that's because breast cancer is more systemic than we realize. True
Yes.
of most diseases. You know, if you look in the peripheral blood of most cancer patients, you'll find circulating cancer cells. Even if they never show up with metastatic disease, they've still got them. So the fact is, we're all at risk for metastatic disease. The role of the surgeon in this is to get tissue for study. This has not been part of their medical school education.
Makes sense. Now, will liquid biopsy work, or obviously you prefer to have
When you
tissue?
say liquid biopsy, do you mean cell-free DNA circulating in the blood, or do you mean getting me tissue for cancer study in vitro?
Probably would be more liquid. Someone
DNA.
trying it and trying to look at the DNA in the.
Yeah. I think that genetic information is incredibly valuable. If you tell me that you have an EGFR mutation, I will know not only to test the EGFR inhibitors, but I will know to test them with other drugs. I have the longest living lung cancer patient with EGFR mutations in the world today. The longest living patient in the United States Veterans Administration with metastatic lung cancer is under my care. It'll be 19 years. I have another patient I'm taking care of as we speak. She presented with brain metastasis. She's 16 years. Why? Because they got exactly the right treatment the first time, and it wasn't necessarily the cookbook outline. It was the combination that worked for them.
So when you get a tissue sample, it sounds like you're able to actually discern the number of different therapies that might work. It's not just a guess of one. It's you're looking at multiple possibilities and combining them if you need to.
Well, remember, when you go to a medical oncologist, they're going to take a look at what you have, what stage, what grade, what features, and they are then going to choose the treatment that's most widely used in your disease.
That's right.
Okay, so that's average patient, average outcome. Do you know that the average outcome in most cancer treatments today, the response rate is less than 50%? Going in to see your medical oncologist, you are a losing proposition.
I did not know that.
Yeah. So when patients are receiving treatment, the doctors, in a way, are looking at a failure in the making. I mean, they don't say that, but they know that the odds of a good outcome in advanced solid tumors is low, yet they don't use every resource at their disposal to make the decisions that could improve the outcome. And the reason is because they were educated in medical school that laboratory tests of human tissue don't work. This is like pharmacology 101. Do not use patients' tissue to predict outcomes. Why? Because they could not make it work. The clonogenic assay didn't work. The thymidine incorporation assay didn't work. The growth to confluence assay didn't work. So they decide they've decided that this can't work. Now, it turns out that Thomas Alva Edison was attempting to find a filament that would carry electricity and create light. And he used cotton and hemp rope and all manners of things. It took him 500 tries to finally get a filament, a tungsten filament, that would illuminate and create light. Now imagine if he'd stopped at 499. So all of these people who think they know what they're talking about are really talking about yesterday's science. They tried it, it didn't work. They're Harvard. They tried it, it didn't work. They're UCLA. So it can't work. It's some sort of papal dictate.
Well, it certainly sounds like the patient has to be a little more proactive in demanding that they get the best treatment that they can. That's why I wanted to bring you forward so that people can see that there are more advanced ways to look at it, and they might have to be the spokesperson for themselves and say, well, I don't really care if you don't want to do it. It's my life. I'd like you to do this for me. If it doesn't work, I'll take responsibility. But it sounds like that's an important aspect for patients to recognize, is that they do have control and they don't necessarily have to just go with what they want to listen to their physician and obviously not dissuade it or not do it, but they also want to look at the things that might work better. And it sounds like you're acting to give people precision, personalized medicine.
And absolutely. And the funny thing is that if you look at the technology that we have applied, we call it the ex vivo analysis of programmed cell death. Brings you right back to the original discussion that cancer doesn't grow too much, it dies too little. So if you're going to predict an outcome, you have to kill the cell outright. Stopping cancer cells from growing is meaningless because they'll grow another day. But if they're dead, they're dead. So that's what you want, a hard edge in measuring drug effect. Number two, the published literature that we and others have contributed to in this field is exceedingly compelling, exceedingly compelling. In 2,581 peer-reviewed published outcomes, patients receiving treatments after they've undergone a test, the patients that get the drugs that appear good in the laboratory in these models have a 2.04 fold higher response rate, p.001, and a 1.44 fold higher 1-year survival, p.02. Now, that's pretty good data for a technology that doesn't work.
It is. I saw the successes from the papers you published and the people that you've dealt with, and it seems like you're not comfortable just sitting on your laurels, but continuing to progress and figure out more innovative ways to do the testing that you're doing.
You know, if you're a medical doctor, you have a very high bar, and it's patient outcome and patient survival. So when a patient comes to you, if you live by the rules and the dictates of your original education and training, your job is to save their life. Absolutely. Or alleviate suffering. And if you have a way to do that, then it is unconscionable that you wouldn't use every tool at your disposal. It seems impossible to me as a medical oncologist that a patient would have something that could work for them and I don't use it. Now, there are patients who come to me and want me to help them, and I think that there may be something available to them that they could use now that I don't need to do a test for. I have a patient, I had a conversation with a woman in St. Louis this past week. I saved her life 4 years ago. And I used an unconventional combination, not an unconventional, but the less widely used combination for HER2-positive breast cancer. And it put her into a stunning remission. Stunning. And now, 4 years later, she still has some residual disease. And there is a treatment that she would be a candidate for. It's a antibody drug conjugate. I think it might work for her. So she said, well, no, I want to come to California and I want you to do another biopsy, because I originally aspirated fluid from her lung. She was riddled with disease. I mean, she had cytologically positive pleural effusion and untreated HER2-positive breast cancer. She was on fire. Anyway, so she wanted to come to me to do a biopsy. And I said, no. There's a drug that is in the market that has a pretty good track record for your disease, and I think you should take that. My job wasn't to sell her an assay. My job is to save her life or to get her better. So we only use these tests when we feel in our heart of hearts it's the right thing for the patient. And when a patient turns up a result that someone doesn't want to use, the flip side of the coin is my one offer to patients is if they won't biopsy you, I will. And if they won't treat you, I will. Now, I'm not looking for business,
Right.
but I do not want we work hard on these tests. And if we take the trouble of parsing very, very carefully considered treatments, and I write a consultative letter with my findings, and I outline exactly what we think will work. And the intent is to leave the patient in the hands of their doctors. I'm not trying to take people away from their doctors, but I will. If a patient can't get the right treatment, then I'll do it.
That's all you can ask. You know, I think that's very important. We've kind of lost that somewhat in our medical careers as things have changed in medicine these last many decades, for sure. Well, I will let you go. I know you have a busy schedule. This has been informative, both to myself and also, I'm sure, to the audience. And I can't thank you enough for taking the time and for explaining what you do and why you do it.
Well, if people are interested, as I said, we wrote a book about this, and it's really an interesting insight into cancer biology because each patient, each survivor is an example of a biological principle playing out in that individual. So what I did was use chapters about patients to describe the biological features of their response. I also talk about some other things like lifestyle and how cancer biology arises and some of the features of it. It's a short read. It's called Outliving Cancer. And the other thing is that people who are interested should just go to our website, the Nagourney Cancer Institute. And we have an outline of what the technology exists. We have a bibliography of our published papers. And physicians who don't know about us or don't believe in this, I'll make an offer. They can get on the phone with me and their patient, and we'll have a discussion of whether I know what I'm talking about or they know what they're talking about. I never lose.
Well, good. That's a positive thing. And it sounded, and you know, dealing with your staff, they're very pleasant and they're very knowledgeable and they know how to arrange things and make it work. So a lot of times that's what happens. You have a good plan and getting it into practice can be difficult, but it sounds like this is very streamlined and there's no problem with people being able to deal with it.
We are so anxious to help. We want to fix the fixables. My dictums are cure the curables, treat the treatables, and where necessary, avoid futile care. And you can use the laboratory tools to make those decisions. Who's curable, who's treatable, and who isn't. And we're not doing that right now. And we're squandering resources and causing undue harm to patients because we're using the wrong drugs at the wrong time. It's very uncomfortable for me. I don't know how people can practice oncology. If I didn't have my laboratory test, I would definitely not be doing this.
Well, thank you. Thank you very much for your time.
Thanks for your time.